evidence and competing arguments. When this does not occur, the chain of trust is broken. In medicine, this chain can at times be delicate in several places. The path from research in the university and its truth-seeking mission, to the education and formation of physicians, to the crafting and dissemination of clinical guidelines by professional organizations and governmental bodies, and also best of the available evidence and competing arguments. When this does not occur, the chain of trust is broken. In medicine, this chain can at times be delicate in several places. The path from research in the university and its truth-seeking mission, to the education and formation of physicians, to the crafting and dissemination of clinical guidelines by professional organizations and governmental bodies, and ultimately, and perhaps most importantly, to the care of the patient is so rich in its potential contributions to society, and simultaneously, because of its scope, it's not always perfect. Fortunately, all of us can nourish and contribute to the integrity of this chain throughout our professional lives. Our three speakers will present, and afterwards, at the end, we will open for Q&A. As is expected with all sessions during the meeting, I kindly ask for your respect for everyone in attendance. We hope that the sessions, such as this one, can continue at future annual meetings. We hope that everyone here leaves with a deeper understanding of the evidence base in this area of medicine. And most importantly, we hope that the research shared and conversations stimulated can serve to build and strengthen professional relationships and ultimately to be used in the service of patients and their families. And before Dr. Lewin starts, Dr. Michael Myers will share a few words. Thank you.
Thank you very much. Thank you for being here, everyone, today. For those of you who maybe came in a little bit earlier, you wouldn't have seen that outside there's been a sign posted that there's no photography or no recording of this session. This is also one of 3 sessions at the APA meeting. No press is permitted. We're looking forward to a very good scientific debate, but you will also see that there are no microphones. And so at the end, or toward the end of the presentations, APA staff will be passing out cards that you can please, write your question out or comment or whatever. We'll bring them up to the front. I'll review them with Christian as well as with counsel, and we'll proceed from there. Thank you. Enjoy the session.
Okay, let me click on this and my slides will appear.
Let's start.
The name of my little talk is 12 Points of Contention. I have nothing really to declare in terms of pharmaceutical connections, but perhaps you might want to know that I write about this topic and sometimes I testify about it. Prior to 2020, concerns about affirmative care, by which we mean social transition, hormones and surgery, were muted by a powerful cultural shift of political, legislative, and medical and secular educational support for trans-identified adults, adolescents, and children. Clinician skeptics were called outliers, transphobes, or trans haters. In the last 4+ years, however, in the United States and many other nations, their media, legislatures, policymakers, and courts, questions have been raised about the moral, ethical, scientific, and constitutional legitimacy of affirmative care. In January of this year, Trump changed federal guidelines by a fiat. The fundamental concern is whether affirmative care is a legitimate, life-enhancing, despair-avoiding treatment, or whether it is another in the long list of medical misadventures. So I'm just going to go through 12 issues of controversy. Number one is what qualifies as compelling scientific evidence, or what we call evidence-based medicine. On the hierarchy of evidence-based medicine, a clinician's expertise, it is shocking to know, is at the bottom. Systematic reviews of studies are at the top. So how much power should a specialty clinic's experience and patient choice have relative to scientific knowledge? That is the pervasive issue. The second issue is, does legal and ethical informed consent require the state of knowledge about what is known and what is unknown to be shared? If we say someone has informed consent, does that mean that the professional has shared everything that is known and everything that is unknown? Third, how long does adolescent gender dysphoria persist over the life cycle? You see, the diagnosis of gender dysphoria has strong inter-rater reliability, but it has never been studied for its predictive validity, which means if someone has gender dysphoria today, does that person have gender dysphoria in 5 years, or 3 months, or 10 years? The actual rate of detransition at 1 year, 5 years, or 10 years is absolutely unknown among the treated and among the never medically treated trans-identified people. The ethical and personal tragedy of detransition after breast or genital surgery is shocking. The fourth contention is the individual developmental pathway to gender dysphoria relevant to medical and surgical decision-making? Wow. How a person got there, is it relevant to how we treat that person? The presumption of a biologic cause of all transgender phenomenon leads to answering this question as no, it's not relevant. Postnatal events are not relevant. Elucidation, however, of the predisposing, precipitating, and maintaining influences on gender dysphoria leads to a resounding yes, of course it is relevant. Fifth, which ethical principles should predominantly shape care patterns? Autonomy of the minor, should that take precedence? Or should above all do no harm and act in the patient's long-term health interests take precedence? Anyway, what constitutes long-term harm? Do we measure that after 1 year, 3 years, 10 years? Or as I say to some adolescents, what's at stake here is the next 60 years of your life. 6, does affirmative care lessen or prevent immediate or long-term suicidal risk? Suicidality, we know, because we're mental health professionals, is a word that covers thoughts, plans, manipulative gestures, attempts with lethal intent and possibility, plus actual death. Immediate effects on suicidality versus long-term harm, long-term effects are quite different. It's easy to see a decreased suicidality after 2 weeks. You see, it's very different story after 2 years. 7, what to do with the majority of trans-identified youth who present with significant comorbidities or poor mental health? Well, one side of the story says, well, give them what they want. They'll get better from all this associated stuff as long as the problem is under good control. So if someone is depressed but is on an antidepressant and is not terribly depressed, go ahead with affirmative care. On the other side is the idea We should treat their mental illness because their negative fate is related to their psychopathology, not simply their gender identity. Should autistic youth receive special treatment considering their maladaptive traits? There's a 7-fold increase in autism in gender services versus the prevalence in the general population. 7-fold. These people often have rigidity, obsession, their friendship challenged, and they have depression, and independent of gender dysphoria, they have a higher suicide rate. So we go back. Do they need special treatment? And 9, what is the purpose of the comprehensive psychiatric evaluation? Is it to identify the candidates of affirmative care? Or is it to plan for effective psychotherapeutic intervention? What are the necessary constituent elements or questions that need to be answered in a comprehensive psychiatric evaluation? Even WPATH and the Endocrine Society recommends a comprehensive psychiatric evaluation, but no one seems to define what elements that should consist of. 10, is the CAS review, which was published in April 2024, trustworthy science? Quickly attacked as biased and the conclusions rejected by 8 prominent authors without peer review were published on the Yale University School of Law website 10 weeks after the CAS review, a 4-year process of study was done. The attack was analyzed, this attack, the Integrity Project from the Yale website, was analyzed by 2 peer-reviewed articles and 1 journalist, all of whom have concluded there's no substantial basis for the Yale attack. The CAS review was accepted as a new national health policy in the UK and Scotland. 11, what is the purpose of psychotherapy for these youth? Is it to support them in their embodiment goals and beliefs that their decisions were good ones? Is that the role of the mental health profession? Or is it to improve their mental health and thereby increase their capacity to reason, exercise autonomy, and cope with the demands of their current and future life? You must ask yourself that question. And finally, how to define the term conversion therapy? Is it any attempt to question the motives, the wisdom, or the legitimacy of the duration of anyone's trans identity? Is that what we're going to call conversion therapy? Or should we look at the past medical misadventures of trying to cure homosexual persons of their attraction? Because that is the basis of the accusation that any attempt to investigate the origins of a transgender identity is conversion therapy. That's a term that we use to describe pre-1974 psychiatric attempts to cure homosexual people of their sexual desires. Is it the same as what we're talking about in taking care of trans youth? Well, that's the issue. Thank you very much.
All right, so it's wonderful to be here. My name is Christopher Kalibi. I'm a professor at the University of South Florida. Like Steve, I've done a little writing, but not anywhere near as much as Dr. Levine. And I've also testified in a few cases. I think that's important for y'all to know. I'm going to talk about the international change of course. It's interesting how little many of the residents and medical students I talk to know about what's been going on around the world. And I think it's important for us to think about that we are caught up in a certain time and place where it's hard to have some of the discussions that I think we really need to have in psychiatry. We have a lot of incredible people in psychiatry. I went to a session this morning, and it was a very nuanced, scientifically, clinically wise conversations on benzodiazepines, and it struck me that somehow we don't have that same level of conversation often when it comes to this topic. I think a lot of people also who are younger, I know my residents and medical students, they don't know much about the original model for what we're calling gender affirming care that came from the Dutch. In the Netherlands, where the first attempts at certainly puberty blockers came from, they had set up a protocol where at 12 years old, you'd get puberty blockers, at 16, you'd get cross-sex hormones, and at 18, you would get surgery. And in this protocol, these were the early onset gender dysphoric youth, so that would be girls, boys, girls that felt a strong identity with the other sex, but did not have psychosocial or psychiatric comorbidities. Those were ruled out and not taken down this path. These are also children that had good family support. These are also kids that had a good comprehension of what the interventions were that they were going to embark upon. There were two published studies, one in 2011 and another in 2014, that created that basically said these interventions, when we look back at, and while these are articles, this was not research, this is just looking back at clinical reviews, but in these cases, after this process had been finished, you had the gender dysphoria alleviated, psychological functioning similar to other age-matched youth, and improvements in psychological functioning in this cohort. So in 2014, you have the second of two papers coming out really supporting this model of treatment and very good outcomes. And around that time, this was then spread around the world. And so only more recently have real substantial critiques of the Dutch model come up. For one, you have to think about the patient cohort. We don't treat type 2 diabetes like we treat type 1 diabetes, right? Different things get treated in different ways. And the Dutch protocol did select early onset and no comorbidities. They also got psychotherapy. Psychotherapy was a part of their treatment, so they had that psychosocial support. Also, while in the paper, but not discussed, not everyone had the outcome that was so great. A lot of them, there was a dropout, so we were only 55 of the original 70, and one died in surgery related to this. So you had a mortality rate of over 1%. Not really discussed in the paper, which I find to be very unusual when you have a death of a healthy person related to it. But there you are. So it seems like we have had what I would call runaway diffusion, and which is the term used in the Abrazizi paper, of a model of treatment that had some bit of research that seemed to be positive, and then all of a sudden this treatment is taken all over the world. Well, Finland was one of the first places to raise questions about this treatment. They started to do this treatment, and what did they find? The youth presenting for treatment did not look like the youth that were studied by the Dutch. Many more females, born female, and many more comorbidities. Plus the numbers were higher. All of a sudden, more and more people were showing up. The Finnish researchers said that severe psychopathology preceding onset of gender dysphoria was at 75%. And they noted that the current research is sparse, and we have a cohort that was different than the original cohort. So do we really know what we should be doing and how to treat this new cohort that's showing up at gender clinics? They called for a systematic review of evidence, and they look at what to do. I think that we have to realize about Finland, Sweden, England, and these other countries that have a more organized medical system is they routinely look at the care that they give in all sorts of things, for surgeries, for diabetes, or whatever it is. They have a mechanism where they understand that as a medical system that pays for and allots the care in an organized, controlled fashion, that they want to look at things. So they take a look. Well, what did they find? They found that a lack of recognition of all these comorbidities can be a serious detriment to the child, and that was one of their concerns. They found that it was their experience that psychiatric symptoms overall were not cured by hormonal or surgical interventions, and that was not a justification for gender reassignment. They found that first-line treatment should be psychosocial supports and psychotherapy. And they said that cross-sex identification, even in extreme cases, generally disappears after puberty. They did an ethical analysis, which I'd encourage you to look at. There's translations of it available. Self-determination primarily manifests as the right to refuse treatments within the available spectrum. What are they saying? They're saying that patient demand for treatments is not a reason to give treatments. And when we say we should have patient autonomy, they should be autonomous to either refuse or accept treatments that we offer. It doesn't mean that they should be able to demand certain treatments. Competence is an important factor. And when you're dealing with a child, you have to consider that you're going in these things with largely irreversible treatments. The issue of competence is profound. You also have the complexity of this new cohort with all the comorbidities commingled with gender dysphoria. So how are we going to move forward, and how do we separate what is coming from issues that are purely gender and what are psychosocial, psychological issues that we are seeing now, which we never saw before? Because I can tell you, when I started medical school in 1995 till 2017, and I saw a lot of patients, and I saw zero patients presenting with gender dysphoria. I now can go to a resident clinic and I have 3 transgender identified patients in a clinic. 20 years, 0 patients, right? So something has changed. And that's not something that changed in the clinics because they're presenting with this. And providing treatments that yield no health benefits and potentially may cause harm is difficult to justify, given that the resources allocated to such treatments aren't necessarily taken away. Once again, a closed system, but we have to think about resources. That's part of the ethical analysis. Now we move to Sweden. They also did a review, started in 2019. They have a number of recommendations along the same lines as what we saw there. They have a systematic review of evidence, which you're welcome to look at. It says the same thing that all the systematic reviews of evidence, that there's very low amount of evidence supporting these treatments. And the guidance, which was previously strong recommendation for affirmative treatments, they had to change to a caution to avoid hormones except in exceptional cases. They came to the conclusion that the risks of hormonal interventions for gender dysphoric youth outweigh the potential benefits. Once again, recommending psychotherapy. And as Dr. Landon said in an interview, these puberty blockers should be considered experimental treatment rather than standard procedure. And now we move to England, where the largest review ever of youth gender medicine was undertaken. I can't give you the whole history of the clinic there, but I would encourage you to read Time to Think by Hannah Barnes. It'll give you a great update on it. But the same thing was found. Look at the chart on the left of how many patients they were getting in the 2000s and what happened in the early 2010s. And they mostly were getting boys in the beginning. And then all of a sudden you have all the girls, and the data is all clear that there's a lot of mix of comorbidities, and we should be thinking what was happening right at that same time. So something has happened in the world where there's a lot more people presenting to these gender clinics. You may also note that social media and the proliferation of smartphones happened just about that same time, which also correlates with a lot of emotional and psychosocial problems. So seemingly, mentioning things like that have become stigmatized within our psychiatric literature and associations, which to me is a profound disservice to the youth that we treat. But for whatever reason, you have this incredible uptake in patients, and they have a centralized clinic. But they have problems because different therapists in the clinic are doing what they think they should do, which is a very haphazard approach. They do not have a standardized approach, and what treatment you got depended more on which therapist you happened to be assigned to than anything else. They also ran a puberty blocker study. Now, they started it in 2011, they finished it in 2014, but they had so much pressure to start giving puberty blockers to everyone that they never published the results. They start giving puberty blockers, and that becomes standard of care, even though they have done a study. So, I mean, it took years for us to finally get the results of the study, and you should look at the McPherson 2023 paper. It's a failed study, right? Puberty blockers did not cause the relief in psychological distress that they were said to. So we've had a study that got buried for a long time. Meanwhile, they're running out these treatments. There were a lot of other things that happened in the UK, including detransitions, court cases, other kind of stuff. And so reasonably, they decided that they're going to have a review. Started in 2020, and the NHS England, once again, a closed system that reviews care routinely. They looked at what are they going to do with their service. They released a report, and I really hope that everyone would look directly at the CAS review, read it, and then make decisions about it based on what you're reading. But it's a lot. It's 232 pages, 56 pages of glossary, appendices, and all that. And, of course, as they do over there, they did a number of systematic reviews of evidence. And so they looked at what's the evidence for social transition, who are the cohorts presenting. They had done a review in the interim on puberty blockers and cross-sex hormones. They did a systematic reviews on those. They did systematic reviews looking at international treatment guidelines. And they did a survey of who's getting treatment. So their aim was to improve care, and they wanted to focus on what they're going to do. But the CAS review was not a guideline. It was basically a review of what's out there, or a review of evidence. We don't have a lot of time, so I'm going to go through some of the findings, and hopefully in the question and answer we can talk more. But basically, the overall is systematic reviews of evidence found that there was poor quality for all of these. We don't have answers to hardly any of these questions. And that we don't have reliable information to make recommendations to patients, and we should be honest that we don't have reliable information. The strengths and weaknesses of the evidence base for the care of gender dysphoric youth has been often misrepresented and overstated. I think that's clear when you look at that and you look at some of the claims that have been floating around for a very long time that seem to keep getting promoted. Evidence-based, life-saving, etc. The rationale for puberty blockers, which is been a moving target. First of all, it was time to think, trying to make sure we're getting the right patient. Then it was, it's to reduce the distress. Well, when we're giving them time to think, and almost everyone who gets puberty blockers goes on to cross-sex hormones, then you have to realize this is not time to think, this is the start of a treatment path, right? Which everyone now knows that that's basically what has been happening with all the kids that start puberty blockers. It wasn't time to think, it was the start of a treatment. And starting very young, right? So Tanner stage 2, you can hit it 9. So we're starting this very young. So we are now at a place where we don't think, the puberty blockers is now, okay, it's all about outcome, and they will look like physically as adults. That's now the new argument for puberty blockers. So once again, this is all a mix, and there's that's a long, complex discussion, but we really don't know exactly what the rationale is, and it doesn't seem that from the CAS review they think it's wise, and they're going to do some research on it. Clinicians cannot determine with any degree of certainty who is going to go on to have an enduring trans identity. I think this is a crucial point. We're calling children transgender, but when they grow up, we have no idea will they have a transgender identity. Seems not wise. Standard, again, psychotherapy, regular supports, these are what we should be giving, and to deny them to kids, we should have a question about whether that's ethical to deny them the regular treatments that they would have had if they didn't have gender dysphoria. Why are we focusing just on the gender dysphoria? So if you look at the CAS review, it says psychosocial first, psychotherapy. It also says, if you look at it, it really is against the affirmative model. It's not for affirmation. it doesn't give you treatment guidelines, but if you read what it says, it basically goes counter to what American associations and WPATH say. And so we have to really take a look at how have things gone wrong in our medical associations and medical societies and in our journals, because we've really failed these kids. And we failed to have a properly scholarly scientific dialogue on these issues. And I think we need to return to that, and then we will do better. But we failed them, and you got my email address there if you got the email.
All right, hello everybody. I'm Dr. McDevitt. I'm going to be talking about comparison of clinical guidelines with a focus on the evidence base. So we're going to start out here with the timeline. I made a pediatric gender medicine timeline, and you'll see here that I started it in '98, and that's because this was the year of the publication of the first case report out of the Dutch Pediatric Gender Clinic of a patient that was treated with puberty blockers in Tanner stage 2 of puberty, and thereafter was put on cross-sex hormones. This next slide, I've highlighted guidelines, statements, or policies over time in green or in red. So green means go and red means stop. So the green guidelines or statements are those that generally recommend hormonal interventions as a standard of care treatment for pediatric patients with gender dysphoria. And then the red guidelines are mean stop. So the red guidelines are those that broadly recommend, more caution. So you'll see, interestingly, before we get into the point of this slide, you'll see that the first green guideline on this timeline was in 2001. At the time, the evidence base consisted solely of a single case report. This was the World Professional Association for Transgender Healthcare, or WPATH's sixth guideline in 2001. And I think, personally, I think that the reason for this is that the psychologist that co-authored this case report and who's broadly credited with inventing the Dutch protocol treatment paradigm co-authored this WPATH guideline, and additionally this endocrine society guideline, this WPATH guideline, and this endocrine society guideline as well. But when you look at this timeline, the thing that becomes apparent immediately is that in the year 2020, we have some red stuff start popping up onto the timeline. And the question for us is why? Why for 20 years did we have like green, and all of a sudden in 2020 we have red? So there's a lot of answers to that question. And I think that my co-presenter spoke to this a bit. Like Dr. Kalebe mentioned, there was an epidemiologic shift starting in the mid-2010s, like around here, where before the patient population had been small numbers of patients presenting, mostly pre-pubertal males with gender dysphoria. In like 2015 or a little before, there was a shift in the patient population, exponential increase in referrals, and that increase was has been utterly dominated till today by adolescent female patients with no or limited history of pre-pubertal gender dysphoria, high rates of mental health comorbidities, and high rates of neurodevelopmental diagnoses. So that's been an issue. There's also been increased attention paid to issues of detransition and regret. We talk about this in pediatric gender medicine specifically because, of course, we consider adolescence to be a time of identity formation and exploration as opposed to adults who have a consolidated identity. There's also been an increased attention paid to the risks of hormonal interventions in youth specifically. So when you're talking about pediatrics and you're talking about the hormonal interventions used for pediatric gender dysphoria, there's some unique risks that are not present when you're talking about adult patients. For example, there's the impact on bone density accrual with puberty blockers. There's the hypothetical kind of risks of what is it going to do to neurocognitive function? What is it going to do to your psychosocial development with puberty blockers? Cross-sex hormones, I'm sure we all know as physicians, have, as all medications do, a risk profile associated with them. An endocrinologist who's starting adult patients who are, starting cross-sex hormones will go over, increasing cardiometabolic risk factors, for males taking estrogen, increased risk of venous thromboembolism. All of that is part of informed consent for adult patients starting cross-sex hormones. If you're starting 13, 14-year-olds on cross-sex hormones, those risks are also going to be, in play. There's also risks that are specific to certain, certain subpopulations of patients. For example, young male patients starting puberty blockers in Tanner stage 2 of puberty, which is that first start of puberty, and thereafter starting estrogen. The Dutch always sort of wrote in their original research that infertility was going to be an expected sequela of this treatment. These patients would be expected to be infertile. The reason is because spermatogenesis, formation of sperm, does not occur until around Tanner stage 4. So, patients starting puberty blockers in Tanner 2 are never going to develop sperm. They're never going to develop fertility or the ability to bank sperm or do fertility preservation. Additionally, those patients, same population, starting puberty blockers in Tanner stage 2, the genitalia are not going to develop past basically a prepubertal size. This has implications for the surgical options for these patients when they are going to get gender-affirming vaginoplasty, should that be desired. The standard procedure for this is to do a penile inversion, which depends on having enough penile and scrotal tissue to use to do that procedure. If you do not have a developed male genitalia, alternate procedures such as colon or intestinal vaginoplasty need to be done. Dr. Kalibi mentioned that there was a patient death in the original cohort of 70 patients treated in the original Dutch protocol research that formed the scientific foundation for this field. So, that patient death, was a, 18-year-old transgender woman, young transgender woman, undergoing vaginoplasty at 18 years old, and had a colon vaginoplasty done. The surgeons who wrote up the case report described that this was done due to insufficient penile tissue for penile inversion. Patient died of neck fash in the ICU post-op. So that was a death rate of 1 out of 70 of the original, young healthy patients treated according to the Dutch protocol in 2011-2014 degree papers. Okay, so that was a sort of list of risk of treatments with respect to puberty blockers and cross-sex hormones. The risk that has emerged onto the map sort of newly, probably within like the past 3 years, is the risk regarding sexual function. So going back to the same population of young males, starting puberty blockers in Tanner 2 and cross-sex hormones thereafter, the former president of the World Professional Association for Transgender Health, WPATH, shared clinical observations that these patients, never developed erogenous sensation, sexual sensation in the genital area, never developed the ability to orgasm. So the risk, that we're talking about here is a possible risk of lifelong sexual dysfunction and inability to orgasm for patients due to hormonal interventions during puberty. So I think all of these things that I've just run through real briefly, I did not get to do a comprehensive sort of overview of everything that's been discussed in the literature. But I think all of that is playing a role in this shift from green to red in 2020. But the most important thing, undoubtedly, is the fact that we started seeing internationally public health authorities commissioning systematic reviews. So here I have on the timeline stars demarcating systematic reviews commissioned internationally by public health authorities, starting in the year 2020 by the Finnish Health Authority, which is the first one. And you see here, it's pretty clear that we have red guidelines internationally emerging after the publication of systematic reviews. Why do we care about systematic reviews? Well, as one of my co-presenters mentioned, systematic reviews, according to evidence-based medicine, EBM, are at the top of the evidence hierarchy. Our expert opinion, our clinical opinion, is on the bottom of this pyramid. In between this are different study types. RCTs, if well done, are going to provide more reliable information than observational data. In the field of pediatric gender medicine, not a single RCT has ever been done. So why do systematic reviews give us such reliable info? Well, the reason is, generally speaking, because systematic reviews are going to review the entire body of literature that has been published on a topic, as opposed to cherry picking, certain studies and just basing your recommendation on those studies. And also systematic reviews, if you do a rigorous, high quality systematic review, are very laborious, intensive processes. So you're going to pre-register your protocol in Prospero or an equivalent database. You're going to have predetermined inclusion and exclusion criteria for your studies. You're gonna have a well-defined PICO, your population, intervention, comparator, and outcome. When you publish your study, you're gonna include all of your search terms, all of your databases, and you're gonna show exactly in your Prismo flow chart how you apply those inclusion and exclusion criteria. And the point of all this is that so researchers coming behind you, searching the same databases in the same way, are gonna end up with the same studies at the end. This is reproducible and transparent, okay? And then once you end up with your bucket of studies at the end of doing your systematic literature search, you're going to then assess these studies for their quality. And this is not like vibes or like opinion based of like, this is a good study, I like it. No, it's the application of standardized methodologic tools to the study that methodologists use to review the studies for quality and give them a rating. And study methodology is going to come into play, risk of bias. And pediatric gender medicine with these observational studies that exist, usually it's been like the ROBUS or the NOS tool that's used to assess study quality. So once you do that, then you look at each study, what was the result? Go to the results section, what was the effective intervention on the outcome? And then, you group that all together, come up with your synthesis, and then you meta-analyze the data. So then you have your result, finally. But then you're still not done, because if you are a very rigorous systematic review, you are then going to need to make some kind of statement about how certain you are that in that result. How certain you are that this result is really what happens in clinics in the real world. And the very most rigorous systematic reviews are going to use something, again, standardized methodologic tools like the GRADE framework to rate evidence certainty from very low to high, so that they can, comment on how likely these results are to be representative of real life. So, that's why systematic reviews are up here at the very top of our pyramid. On the next couple slides, we're going to just look very briefly at a table from one of my publications in this field that lists systematic reviews. And the point of this table is not to go over everything, but just to note that there's been many systematic reviews done, not just once commissioned internationally by health authorities. And in this table, I do have the appraisal method for how reviewers appraised individual studies, how they appraise body of evidence, whether the review rated certainty of evidence on an outcome basis. And here in the rightmost column, we have conclusions of the systematic reviews that have been done in pediatric gender medicine, and this is specifically for hormonal interventions. So we are going to review, on the subsequent slide, we're going to take the most rigorous systematic reviews, and we are going to look at that rightmost column. So what were the conclusions that the systematic reviewers reached about hormonal interventions for pediatric gender dysphoria, with emphasis added by me in bold. So gender reassignment of minors is an experimental practice. Evidence is very low certainty using GRADE. There is great uncertainty about the effects. Evidence is insufficient. Evidence is lacking. Evidence base is not sufficient. It is unproven what the effects of interventions may be on SI, other suicidality. Lack of high quality research, no conclusions can be drawn. Lack of high quality research is very limited. Quality of evidence is low, high risk of bias, dearth and poor quality of evidence. Evidence is very low certainty per grade, or not per grade. Evidence is very low certainty. Considerable uncertainty regarding the effects, considerable uncertainty regarding the effects. We are very uncertain. So you'll see here, there is remarkable consistency among the conclusions of all the rigorous systematic reviews that have been done in pediatric gender medicine with respect to hormonal interventions. And now evidence-based medicine sort of speak and lingo can get a little bit in the weeds. So we are going to put it in very plain English, to sum up the sort of nature of the weak evidence base in this field with the following statement. Based on what we currently know scientifically, we cannot say with any reasonable degree of certainty what type of effect hormonal interventions may have on mental health outcomes in pediatric patients with gender dysphoria. It could be a positive effect, it could be a negative effect, it could be a neutral effect. We do not know. Another reason we should care about systematic reviews is they should be what's underlying our trustworthy clinical practice guidelines. This slide is from National Academy of Medicine, formerly the Institutes of Medicine guidance. And the number one thing, according to the NAM, is that trustworthy clinical practice guidelines, or CPGs, should be based on a systematic review of the evidence. This is number one, foundational. All of our trustworthy CPGs should be based on a systematic review of the evidence. Now in pediatric gender medicine, so Dr. Kalibi mentioned that, went through some of the changes in the guidelines from Europe. So what I've done on this slide is I've generalized a bit here. So we have in the year 2025, looking internationally, we have two different types of guidelines, generally speaking. First, on the left side of the screen here, we have guidelines that recommend psychotherapeutic approaches as a standard treatment practice for pediatric patients with gender dysphoria. Right, so we have the Finnish CPG, the Swedish CPG, and then in the UK, we don't have a CPG, but we have the Comprehensive CAS Review, which gave recommendations to the NHS, and then the NHS is now implementing those recs. And then on the right column, we have guidelines that recommend hormonal interventions and or surgeries, or hormonal interventions and surgeries, I should say, or as standard treatment practice for pediatric patients with gender dysphoria. Again, we have a WPATH CPG, an Endocrine Society CPG, and the AAP policy statement reaffirmed in 2023. Like what I said earlier, this is not technically a CPG, it's a policy statement. These two are CPGs. You'll note that this is what we follow in the United States. I say we as in, clinicians in the US, the WPATH and Endocrine Society CPGs are what dictate clinical practice. So our job for the last part of this talk is to look at these two different groups of guidelines and do some comparison. If you'll recall, trustworthy CPGs should be based on a systematic review of the evidence. So which of these guidelines were based on systematic reviews of the evidence that were commissioned? And the answer is, the ones that recommend psychotherapeutic approaches. We see in Finland in 2019, their CPG was based on their systematic review that was commissioned. In Sweden, Ludvigsen was the systematic review that was commissioned to underlie their CPG. Swedish CPG also references heavily two systematic reviews done by the National Institutes of Health and Care Excellence in the UK in 2020. And then of course we have the CAS review, which has its two commissioned systematic reviews down here. Again, we're just talking about hormonal interventions here. CAS review actually commissioned many systematic reviews. And then also heavily referenced these other systematic reviews that have been done. Whereas, if you look at Endo Society, WPATH, and the AAP, there were no systematic reviews that were commissioned to underlie the guidance with respect to pediatrics and use of hormonal interventions in this population. I want to take a brief aside. We're going to sort of table the current conversation for a moment, and we are going to look at, WPATH and the CAS review, because WPATH has the most influential CPG in this field, and really is the driver of a lot of clinical care with their 2022 CPG. And then the CAS review is extremely important internationally. So I think these are the two most important players, and so we're gonna look at them a little bit and with a little bit more closely. Specifically, I wanna point out a very confusing, at least to me, response that WPATH as an organization had to the CAS review's publication last year. So if you look at this slide, these are all of the systematic reviews of pediatric gender medicine and hormones that were referenced in the CAS review. And these are the ones that were referenced, and these were the ones that were referenced in the WPATH CPG. This one is very old, and this one I don't think actually meets criteria to be considered a rigorous systematic review. And then look at the number that were referenced in the CAS review. So given, keep this slide in mind, and let's look at what WPATH said in response to the CAS review's publication. In contrast to what the CAS review recommends, WPATH firmly stands by our guidelines, which were published in 2022 and based on far more systematic reviews than the CAS review. To me, the math is not mathing with that statement. And additionally, WPATH's adolescence chapter, their CPG on adolescence, states a systematic review of treatment in adolescence is not possible. The two that were in that column earlier, were referenced in another chapter in passing, not as like underlying recs, but just sort of like referenced in passing. And then this chapter says, and this is the main chapter about, hormones in adolescence, systematic review is not possible. But of course, remember our timelines. Systematic reviews had already come out by the time WPATH's CPG was published in 2022. And the situation actually gets a bit worse when it was revealed last year that WPATH reportedly, allegedly, had in fact commissioned a systematic review of hormonal interventions in pediatric patients with gender dysphoria from Johns Hopkins University researchers, reportedly did not like the results of that systematic review and then interfered with its publication. So, in my opinion, this does veer out of the territory of run-of-the-mill publication bias, which pediatric gender medicine, I think, has a bit more than a run-of-the-mill publication bias problem. But this, I think, veers out of that territory into a realm of evidence suppression, research, academic, and scientific misconduct. Back to our point of comparison of clinical guidelines, okay? So now we are going to look at a systematic guideline appraisal that was published last year, comparing pediatric gender medicine guidelines internationally, according to a standardized methodologic scale using the agree-to tool. Recall earlier we talked about how methodologists use standardized methodologic tools, when they're doing systematic reviews and rating studies for risk of bias, etc. So there are also tools that reviewers, methodologists can use to, assess and appraise CPGs. So this is what this paper last year did. And you see here that there is a systematic appraisal of guidelines. So before we get to the results of the agreed-to sort of application, we're going to look at something else that these reviewers found. So this is speaking to the interrelatedness and interconnectivity of guidelines that were published prior to the year 2020. So look up here in the leftmost top quadrant, A. So this is a timeline. The x-axis is time, is years. This is showing how many guidelines internationally that recommend hormonal interventions for pediatric gender dysphoria, how many of them were based on an older Endo-Society guideline. Okay, so basically all of these, so we see APA, ACAP, I think that's the other APA. All of these guidelines reiterated Endo-Society guidelines. Okay, and then this B is showing the same thing for an older version of WPATH guidelines. How many international guidelines popped up that just reiterated what WPATH had said? And then this quadrant shows how these guidelines referenced each other in making recommendations and supporting recommendations for hormonal interventions. And then the last one puts it all together. And you see here on this slide C2 that the newer WPATH and Endo-Society guidelines then referenced all these other guidelines that themselves had referenced older WPATH and Endo-Society guidance. So the CAS review, I think, put it very nicely when it had this sentence. The circularity of this approach may explain why there has been an apparent consensus on key areas of practice despite the evidence being poor. And I saw it described well in another publication recently that said that there has been a pattern of circular referencing and mutual endorsement when you look at guidelines in this field on it internationally. All right, so back to our agree-to sort of appraisal of how these guidelines scored. This is a slide showing the scores that were given to the different guidelines. The Finnish and the Swedish guidelines were ranked highly on average, and they were recommended for practice by all reviewers. The agreed-to assessments of the guidelines that recommend hormonal interventions were ranked lower and were not recommended for clinical implementation. So, the takeaways from the systematic guideline appraisal published last year are the following for WPATH and Endo-Society guidelines specifically, which, like I mentioned, are those that seem to be followed by clinicians in the United States. These guidelines did not follow international standards for guideline development. There was a lack of an evidence-based approach. These guidelines were linked by co-sponsorship. In addition to the issue we looked at earlier with sort of the circular referencing issue, one of these organizations actually sponsored the other's guideline development with respect to pediatric gender medicine. These guidelines lacked developmental rigor and transparency. They were not recommended for clinical implementation. And then most importantly, what we all need to really realize is that these guidelines did not make recommendations commensurate with evidence from systematic reviews. Comparatively, the takeaways from the systematic guideline appraisal of the Finnish and Swedish CPGs found the following: that they did follow international standards for guideline development, had transparent processes, they were recommended for clinical implementation, included formal ethics reviews, scored highly for stakeholder involvement, and they did make recommendations commensurate with evidence from systematic reviews. they were dinged because they could have benefited from more detail regarding recs for psychotherapeutic approaches. So, in conclusion, what I think we can conclude based on the systematic appraisal of guidelines is that those guidelines that recommend psychotherapeutic approaches as a standard treatment response for pediatric patients with gender dysphoria are based on systematic reviews and are trustworthy, reliable CPGs. Contrastingly, those guidelines that recommend hormonal interventions and surgeries as a standard treatment response for pediatric gender dysphoria are not based on systematic reviews and are not trustworthy or reliable CPGs. So, where do we go from here, in my opinion? Okay, in my opinion. So I think that we need trustworthy, reliable CPGs in the United States. We need to commission these CPGs from developers without conflicts of interest. I think we need to be prioritizing high quality evidence-based education with respect to CME, but most importantly, with respect to how we're educating our residents and our med students. And finally, a few notes in my thoughts for physicians in the audience and for the APA as an organization. I would consider adjusting your practice to align with the best available evidence in this field. I will say professionally, clinicians who I meet and who I've met that have a heart for treating this patient population, who do recommend hormonal interventions according to the current guidelines that are followed in the US, are uniformly the most caring, compassionate doctors that I meet. They really, want to do right by a vulnerable group, by a minority group. That is all extremely admirable and laudable. However, it is also true that we don't know what we don't know until we do know it. And when we do become aware of higher level scientific information, it does become incumbent upon us to change our practice accordingly, as we would do in any other area of medicine. We should not be exceptionalizing care for pediatric gender dysphoria. We should be treating it as we would any other thing in the medical field. Somewhat relatedly, I would encourage the application of a medical ethics and equity framework to this pediatric clinical area. So from my sort of conceptualization and knowledge of this issue, it seems that we have a patient group of young people, of children and adolescents, who either identify as trans or they have symptoms of gender dysphoria. However you want to verbalize or describe, this population, we are treating them with hormonal interventions that may, have risks of causing infertility and potentially lifelong sexual dysfunction and inability to ever experience sexual pleasure. Kids that don't have these experiences are not, treated with interventions that cause those things or have, plausible risks of causing those things. So from a perspective of justice, which is one of our four pillars of medical ethics, I think that we need to be incorporating that perspective. Equity is foundational to psychiatry, practice of psychiatry. I would encourage, using this sort of framework, this perspective, integrating it into the overarching desire and call to protect trans kids. I would also increase your reliance upon primary sources in this field. You all may know that this is an incredibly controversial, polarizing, politicized topic. Unfortunately, with this very specific, very niche sort of, but I think very important, but very, very particular thing, it is not going to be enough to read the wiki page. It's not going to be enough to read the Medscape or the MedPage article or the news article, and very unfortunately, it's not going to be enough to read what our U.S. professional medical organizations are saying in their statements. I do hope that, one day that may change. But for now, you do need to, for example, read the CAS review for yourself. It is not going to be enough to read what somebody else tells you about it. Finally, I think we can nonetheless demand high-quality, evidence-based, ethical, and comprehensive guidance from our leadership, from our professional organizations, and continue to demand robust and critical discussion of this issue. I'm very thankful that the APA accepted this talk to occur today. I know that things like this don't always get accepted, but I hope that it's a sign that there will be continued, robust discussion of these extremely important issues. I'm going to leave this quote on the screen while we open it up for questions. Thank you so much for having me today.
Thank you everyone for your time. So I understand there's a specific new protocol for asking questions. I believe cards were passed and we will collect them and share them with the crowd. Okay, I think they're being passed around now, right down the center aisle. So I want this to be one of the richest discussions of the entire meeting. So we have at least half an hour for that. So I'm sure everyone has as many questions as possible. Feel free to submit